Good afternoon, everybody, and thank you for being here. We are informed that there are a lot of you out there, and it's quite a pity that we cannot see everyone and each of you. So this webinar from the European Association of Urology is dedicated to stones, of course. And as the technology is improving the last 5 years, we are creating more and more dust to our patients because we want them to be stone-free after our operations. So it is dedicated, this webinar, to stone dust, and if there is a difference in the new lasers that are out in the market, or if different technologies and techniques really plays a different role to render our patients stone-free with less complications. Together, we have 3 excellent speakers and very experienced in the stone surgery. With us is Thanos Papachouris. He's a professor of urology in Athens Medical School in Greece, and I have the honor to work together with Thanos. Eugenio Ventimiglia from San Raffaele is with us, and he will discuss for the lasers. And of course, Victoria, the lady of the company, from Victoria Joris from Vienna University. She will discuss about the suction and the role that the suction plays in our new technology that we are using. I would be really thankful to you if you will try and be interactive. I know at the webinar is very difficult to be interactive, but you have the Q&A button at your screens in front of you. Please try to send us a lot of questions, because I think it's very, very important to have your questions, and we will try in between the lectures and at the end of the this webinar to reply to each one of these questions. So I will introduce, to start, I will introduce Thanos Papachouris. Thanos will discuss about the stone dust, the definition, the stone-free rates, and of course how we should follow up our patients. Thanos, welcome, and please start your presentation.
Yes, thank you, Andreas. I believe that you can see my first slide. So I would like to thank European Association of Urology and European School of Urology for the very kind invitation, and all of you being here. I know mid of July is a period of vacations for most of Mediterranean countries, but for us, practical topics like this that we're going to discuss today are of great clinical significance in order to help our patients. So let's get started. We have published with ESEUT the trends in urolithiasis management, and as we can see, we have more and more publications regarding REERS and PCNL. But the last 5 years, as Andreas mentioned, most of the publications are in favor of technologies that improve the performance of REERS. But of course, it's not only the treatment modality that we are going to decide, but there are several parameters that will affect the management of our patient and the efficacy of our treatment. So we have the stone size, the volume, the number of stones, the composition that we can predict with our enhanced CT. We have the renal anatomy, and of course the patient. So we don't treat just a stone, we treat a stone in a kidney or a ureter in a patient. And we take into account all these parameters when we are going to decide what to do. We are now using rears and not ureteroscopy, because from semi-rigid ureteroscopes we have moved to the flexible ureteroscopes, and we now have the digital scopes, the disposable or single-use scopes. We have very slim scopes, and this can help us access all parts of the PC system. And once we have the stone in front of us, we are not using now the pneumatic as in the past, where we had fragments, but we are using the laser. So there is a trend, and we have been moving from breaking a stone into pieces with a pneumatic lithotripter to laser the stone into dust, as Andreas mentioned. Because actually, we're afraid that the stone fragments that will produce will actually cause some complications in the future, readmissions, need of retreatment. So as the patient will ask us at the end of the operation, have you get rid of the stone? 100%, we should be very, very meticulous into achieving the best possible stone-free rate. So in the treatment modalities that we have, we can choose either to laser the stone, as you can see here on the left, or have fragments that we're going to get out. Now, the issue with taking out fragments is that you are going to use either a basket or a grasper. And sometimes you may get into trouble if you have big fragments that you are trying to get out. Sometimes your basket could be trapped, and sometimes you may injure the ureter, and it's mandatory to use ureteric access sheath in order to go ahead with your basketing. So there's an issue also of this cost by using these baskets and graspers. And also it's different to laser or fragment a stone, laser a stone with dusting or fragmentation technique into the lower pole or in the pelvis or upper pole. So there are some techniques that you can use to make your life more easy or more difficult if you are not doing what you are supposed to do or what you have planned. As we all know, high frequency and low energy Holmium laser will end up with dusting. High energy, low frequency will end up with fragmentation. So when we are using dusting, we may have a shorter operative time and lower operating cost because we are not using the graspers or the baskets. And if we are using, when we laser the fragmentation technique, we will for sure send fragments for stone analysis. But still, although we like dusting, if we are treating big stones, we are tempted to actually get some fragments that will be small, and we may say that these fragments are very small, it's dusting, so we are happy with the operation. Sometimes we have a time limit of 1 hour, 1 hour and a half, and we're a bit anxious that we don't have the dusting effect that we want, and at the end, we make bigger fragments. So it's very important for all of us to have a consensus regarding what are the stone fragments, the residual stone fragments. So I'm sure that you are familiar with the dusting, fragmentation, popcorning, and pop dusting techniques. And some lasers now have these modalities in the program, and you may choose the type of the technique that you're going to use. And actually, there are new flexible scopes now in the market. that have several modalities, like suction modalities. We'll discuss this later on. And there are under investigations new flexible digital scopes that actually, with the image, they could assess the composition of the stone and actually recommend relevant lasering settings. So these are innovations that will come, and maybe in the future, the scope will actually have some options and some predictions of the best technique. So we won't manually insert the energy settings that we are usually setting for frequency and the other parameters. Now, as we all know, and in the era of the guidelines, we have to follow RCS, randomized control studies and trials. So when we actually compare dusting and fragmentation, when we are doing the lasering, we have a lower operating time and cost, but the lasering time is longer. And it makes sense because we are working more on the stone. But it depends if we are assessing the efficacy as a short term or as a long term, because in the long term effect, we may have no difference, but just after the operation, the basketing seems to be more superior. As after performing ESWL, we have a different stone-free rate if we are assessing the result a few days after or 3 months after, because we have some spontaneous passage of residual fragments, as we all know. Now, the fragments could be clinically significant or insignificant. So we have several recommendations, such as the stone-free rate level. So it could be 0, 1, 2, 3, and 4. To be honest, it's not easy to measure fragments up to 1 millimeter, even with an enhanced CT, because as we know, even when we have slices of CT very thin, they would be 2 millimeters. So actually the 2 millimeters is a limit where you could actually assess with your imaging the results. And actually 2 millimeters is an agreeable size regarding the stone-free status. So if we have such fragments up to 2 millimeters, then we are fine. If we have more than 2 millimeters, then there is a risk of a stone-related event and a need of retreatment. So it's good for you to have this knowledge. 2 millimeter is a size where we need to take into account. In the past, we were using the 4 to 5 millimeters as a clinical insignificant fragment size, because as we knew, up to 80% of stones that are 4 to 5 millimeters could pass spontaneously from the ureter. And we say that we insert a JJ stent, and these fragments could be easily passing through the ureter, even when we get out the JJ stent. And if we use very small stents, 4.8 French, then they could pass some of them next to the stent. It depends how much the ureter is dilated. But for sure, if we have fragments up to 4 millimeters, we may have, in 1 out of 3 cases, some stone-related event later on. So the 2 millimeters is desirable and not the 4 millimeter as in the past. I won't go through busy slides, but there are studies where we can actually have this in comparison with several other publications. A very nice work published by Oliver's team is what is the exact definition of stone dust. And this was actually defined with in vitro studies And very practical, we could say that dust is whatever can be fully aspirated through the working channel. As we all know, the size of a working channel nowadays is up to 3.6 French. So once we can aspirate all this dust, that is the proper dust. If it can't pass through the working channel, then it's not dust. And according to floating and sedimentation properties in vitro, the team found that below 250 micrometers, we have the proper dust, regardless of the stone composition. It may be different regarding the struvite stone, could be less than 125, but bear in mind this 250 micrometer as the definition of the stone dust. Very nice work recently published, and in World Journal of Urology a couple of months ago, we had also a nice review regarding the clinically significant residual fragments that would be up to 2 millimeters, as I mentioned before, on post-op non-contrast CT. So we have actually recently these definitions, and we may have a consensus regarding this. But of course, it's nice to have the exact measurements of what we see. So this is the image from the 2 millimeter fragments and of the dust. And it's very common when we actually cannot see very well, when we are in a closed system with not a lot of irrigation. We have a blur image. And this is a disadvantage of having very, very thin dust. So these are the ideal, desirable results that we should have when we are doing our lasering. And we may have the dust hills, as we say, as we have sandstorms. It means that we have accumulation of dust in several parts of the PC. And this could impair our imaging and our maneuverability. And sometimes we may underestimate remaining fragments because of this dust hill. So it's very important to flash and be very sure what you have left behind. And sometimes when you see a dust hill, you need to make sure that there are no residual fragments. Regarding the lasers, this will be presented from the following speaker, but we all know that we have different optimal power settings for different compositions of the stones, and we have different settings regarding stones in the kidney or in the ureter, and also we have different pulse modulations like the Moses effect. For sure, the new Kegelon block, the blockbuster of thulium laser, makes our life easier as we have a stronger laser, we have thinner fibers, and that means by having this, we have less retropulsion and we have better dusting. So studies have shown that with thulium laser, because we may have frequency levels up to 2000 Hertz, we have better dusting. And studies regarding URS and even mini PCNL have demonstrated that the final stone-free rate could be up to 98%. So the thulium laser, as will be presented later, is a very powerful laser that achieves in a quicker way a very good result. And it may actually take the place of the Holmium laser. Other innovations are the bendable accessives with suction, because we may have dust or small fragments in the lower calyx, and by using this bendable accessive with suction modality, we may have small fragments out, we may have dust out. So it's a very good gadget, accessory that we can use with a flexible scope. And all this will improve our efficacy and the stone-free rate. Even we have new disposable scopes that we have suction modality inside the scope. At the end of the day, we need to assess and know the exact fragments after the operation in order to be aware of the follow-up. And the guidelines have taken this into account, because the follow-up will be different for stone-free patients, for patients with residual fragments, and high-risk patients. I won't take more of your time, because this can be read in the guidelines. This is the 2024 edition, where nicely it has been demonstrated in the tables what the follow-up should be, how often regarding stone-free patients, patients with residual fragments, in general population or in high-risk population. From 6 months up to 60 months, we need to do a regular follow-up, because as we know, a stone patient can recur very easily. And instead of epilogue, as a new thing that has been discussed, I just put the artificial intelligence, because we may be able to predict the stone-free status based upon residual dust assessment. And there are several neural networks that can help us. This was presented in EAU this year. Thank you very much for your kind attention, and I'll give the podium to Andreas. Thanks a lot once again.
Tano, thank you so much for the very nice presentation. You left us speechless because there are no questions for you from the audience. I strongly recommend everyone out there to send your questions, and actually send your clinical questions that you are confronted to in your everyday practice. Evgenio and Victoria, please open your cameras also, because I will give a couple of questions to Thanos, but you are also invited if you want to reply. Thano, so we are discussing about dust. Okay, that's the topic of the day. In your everyday practice, do you always do dusting in the ureter and the kidney? On how do you decide upon creating fragments and remove them, or creating dusting? Give me your tips.
Yes, yes.
Tips and tricks.
You know better than anyone that the stone is not homogeneous. So you may have the periphery of the stone being more soft, and we start with dusting, the painting technique. But sometimes the inner of the stone is harder, and we change the settings. And if the stone is big, because we know that with rears, we now gonna treat stones up to 2 centimeters, sometimes 2 to 3 centimeters. So if we are progressing and with the dusting we are not so quick, we may have the temptation of doing a bit of fragmentation. So that's a very crucial point where we need to make sure that these fragments won't be big. So I start with dusting, but I'm not sure that I will end up with dusting. It depends for all these parameters that I've mentioned. Thank you.
Victoria, I know that you will extensively discuss about this later on, but now with all the suction that we are having, and I know, correct me if I'm wrong, that we can suction actually large fragments also with the new devices. So do we need the dust, you think? Just a comment. And please unmute, Victoria.
I think as we heard, I think still with the suction, it really depends on the situation, on the patient, on the stone, what is best suitable, and should be an individual decision, and also what kind of suctioning you're applying. But this is definitely something to keep in mind when deciding on which devices, which instruments to use before the surgery.
Okay, now we have 4 questions, Thanos, for you, and everyone can reply actually. First of all, how much time you leave a stent, especially if you're creating dust, Thanos, I would say. That's the first question that we have. How long you will leave the stent?
I mean, usually 2 weeks is enough, and it depends if we have lower urinary tract symptoms and if it's uncomplicated, the whole process. So on average, it's about 2 weeks.
Okay, and you mentioned in your presentation about the different types of fragmentation and the dusting and popcorning. What do you think about the popcorning? This is do you do popcorning or pop dusting? I would modify a little bit the question. What would you prefer?
Yes, I mean, the popcorning is something ideal when we have a small callus where actually the fragments could hit each other. So also sometimes you are not able to do the dusting by approaching the stone with the fiber, and you are just in the middle of a small calyx, and you leave the popcorning do the rest. So it depends from the anatomy, actually. Thank you.
Okay, so there's no right or wrong. I had also the same question, but this is also a question from the audience, because you mentioned a lot that we should judge the stone-free rate by using the CT scan. How often, guys, do you use the CT scan to follow up your patients and what you did to your patient? How often you do it?
I can start, yes, by saying that it's a desirable imaging modality, but we have to take into consideration the fact that patients are reluctant to do very often CT scans because of the radiation. So if you're in a department where we can have a low radiation CT, CAT scan, then it's something that we propose, but practically speaking, we don't do it as often as we should do it.
For the sake of the time of our webinar, within the guidelines, I'm talking to all the participants, we recommend the CT scan only when we need or we think our patients need intervention. So we do not recommend CT scan for everybody. We recommend US and a KUB instead of a CT scan. This is for the clinical practice. For scientific reasons, is different. There is one more question, but I think I will give this question to Eugenio because it's really the best question for you to start your presentation, Eugenio, is what type of laser machine you use in your clinical practice? This is one question from the audience, so please start your presentation and then we will discuss again.
Good evening, everybody, and thank you, Professor Skolarikos, and thank you to the EU for the invitation. And I also have to thank Professor Parpatsoris because he did a wonderful job with this first talk, and it will make the understanding of my talk much, much easier. So I have no conflict of interest. I'll try to begin with few technical comments, not the very boring ones, but just the ones that will make us, let's say, that make our life easier, trying to understand how laser works and how it works when we want to get and to obtain stones in terms of dust or fragments in our practice. So very quickly, laser is basically light. It's light which is emitted at a specific wavelength, which goes in a single direction, which is amplified in order to achieve a desired effect. The reason we don't see light coming out of the laser fiber, it is because the laser is emitting in the infrared spectrum, and this very simple reason makes us not to see the light, but see the effect that we have on the stone. Very quickly, the lasers I'm going to focus on are the ones you see here. Basically, Holmium, we see and we know Holmium since many, many years. There are new Thulium lasers, like Thulium YAG, which works in pulsated way, which is able to treat stones, and of course, Thulium fiber lasers, which is the new kid on the block that you are keep on hearing much about it. Just very few comments. Our lasers, when it comes to endourological procedures, they function in aqueous solution. They can be either continuous or pulsated, but if you want to treat stones, continuous wave lasers, they are not useful. There is a concept of total power, which is very well stressed by companies, but at the end of the day, as the guidelines say, it is not very useful for a practice. And most importantly, we need to understand how different lasers interact with the stone, because this can help us choosing the best laser in our practice. There are some ingredients that can assist us if we want to produce dust, if we are dusters, or if we prefer to fragment according to our specific technique. Of course, it depends on the laser that you're trying to use. It may depend on the laser power, but especially on the laser settings that you're going to choose, and specifically on the technique that you want to use, as it was shown before by Professor Papazzoris. Very quickly, like I said before, the reason why we need a pulsated emission is that a continuous emission will not be able to reach a power, especially a peak power, which will be high enough to dust and fragment stones. This is the reason why if you have a continuous laser which works only in continuous way, it will not be able to treat your stones. Like I said before, the concept of total power is there. Companies stress and they want to push the concept, the high power lasers, they are necessarily better than low power lasers. Actually, it is shown that it's not like that. You need an high power lasers if you want to do prostate surgery, but for stones, low power lasers, they can be enough for most of the stones that you are going to treat. Let's get a little bit more into the details, how lasers are working in our practice. This is a functioning of the Holmium YAG. It might seem complicated from the picture, but the real concept that we need to understand is that there is a light of a specific wavelength, which is 2100 nanometers, which is selected by a crystal, amplified, and then emitted by the laser. You see that the functioning of the Holmium YAG laser is quite similar if you have a low power or a high power machine. The difference is that several crystals are built in together within the machine in order to achieve a higher effect and a higher power in order to increase the total declared power of the machine. Thulium YAG has a similar infrastructure to Holmium. The difference is that you have laser diodes that make the functioning a little bit different, and at the end of the day, the crystal will select a slightly different wavelength, which is the one you see here, but eventually the totally different laser in terms of functioning that we have nowadays available in our practice is thulium fiber laser. It doesn't have a crystal, it has a fiber, and it's called a thulium because within the fiber you have thulium ions which work stimulated by laser diodes with an emitted wavelength of 1940 nanometers. A little bit more interesting than the functioning of the laser itself is what happens when you are trying to dust your stone. There is an interaction between the light and the stone, but before that we have to remember that the laser is working in water when we are doing our procedures. And the way the different lasers interact with the water, it depends a lot on the way the laser is absorbed by the water. So if we see the emission wavelength of thulium fiber laser, it is quite higher than Holmium YAG, for instance. And this will determine important differences, as we are going to see in a while, starting from the very bubble which creates at the tip of the laser fiber tip. Another concept which may appear complicated, but which is fundamentally to understand, is the concept of peak power and pulse duration. You may think it this way, which is if you have an energy, which is 1 joule, for instance, for a pulse, you can distribute this energy on a long time, which will be more gently delivered to the stone, and this will decrease the peak power. At the same time, you can have the same energy which is distributed in a very short pulse, and this will be very abruptly delivered to the stone, which will have a much more impact in terms of fragmentation of the stone, a less gentle delivery, whereas a more gentle delivery of a low peak power pulse will have, in the end, a more dusting effect. In a way, this is quite well explained by the theory of the photothermal effect and the photoacoustic effect. Very simply, what we need to know is that the bubble creates an explosion and a collapse, And this explosion of the bubble that we've seen before creates a shockwave, which will be able to fragment the stone. At the same time, some of the energy will not be absorbed by the water and will hit the stone directly, creating the photothermal effect. Just to understand it more clearly, if we see here a stone in which we treated kind of favoring the photothermal effect, what we see is that there is a chemical change in the composition of the stone and a burning of the stone because the light is hitting directly the stone. On the other end, when we have the bubble exploding in front of the stone, the effect is quite different. As you can see here, there are cracks creating in the crystalline structure of the stone, which in a way explains much better the way that the pulse with a high peak power might interact, fragmenting the stone, whereas the laser, which kind of favors the photothermal effect, we create dusting without fracturing the stone in an important way. All this introduction is very useful in order to understand the concept of different lasers and the way different lasers interact with the stones. If you see here, we have Holmium YAG, and you can see that the peak power of Holmium YAG is much, much higher as compared to pulsed Thulium YAG and Thulium fiber laser. In a way, if you see and if you have a look at the bubble created by Holmium YAG, it is a very big and very explosive bubble. This means that whenever this bubble is exploding in front of the stone, it will create a kind of fragmentation effect and also some degrees, and to a certain degree, also a big retropulsive effect. At the same time, Thulium fiber laser, much lower peak power, more gentle delivery of the energy to the stone, and at the same time, you will have a much more pronounced dusting effect. We also have some type of modulation with Holmium YAG. As you can see here, it is possible to have long pulse with lower peak power, but also it is possible to have a double pulse, which will kind of lower the peak power, trying to decrease this abrupt effect of Holmium YAG in a way to improve the dusting capability of this laser. So at the end of the day, we have stones. We want to do dusting. We want to do fragmentations. What do we need from our lasers? What really matters? Of course, it matters the laser type. We've seen the theory. If we go to the lab, what we see is that for the same settings, Thulium fiber laser is able to produce much smaller fragments as compared to Holmium YAG. At the same time, the proportion of big fragments for Holmium YAG will be much bigger for the same setting as compared to TFL. So it works in the theory and it works in the lab. We have much more retropulsion with Holmium YAG as compared with Thulium fiber laser, and we understand it because we have a more abrupt effect on the stone. We have more fragmentation for sample specific settings, and we will have more retropulsion. The concept of laser power, again, it seems to work. If we have higher powers, we get to see always in the lab that the proportion of smaller fragments and dust will be higher and more effective. But at the same time, you also see from clinical studies and from the guidelines that are led by Professor Skolarikos that high power lasers may be helpful, but at the same time, if you are an experienced endourologist, you will not get a big advantage in terms of stone-free rate when treating stones with high power or low power lasers. Settings, of course, they are fundamental. Professor Papatsoris very well explained this before. As you can see here, this was an historic slide by Professor Traxer. You get to see that if you want to achieve dusting, what you need is low energy. And of course, if you increase your frequency, your speed of working will increase as well. For fragmentation and Holmium, you need high energy. And for popcorning, of course, you need high energy and high frequency. Long pulse is definitely recommended for dusting because the peak power is lower and you have a less abrupt effect. At the same time, short pulse is definitely recommended for fragmentation. You can see here that when we discuss settings for Thulium fiber laser, the situation is not as clear as it is, because we see that there is not a big agreement, but at the same time, what we see in the evolution during time, the settings that we need to use for TFL are much similar to the ones for Holmium. And again, TFL has a theoretic advantage. It seems to have a kind of advantage also in the clinic, but we need to wait for more clinical results. And eventually, surgical technique, this is the key factor, of course. It depends whether you're a duster or a fragmenter, according to what you prefer. And we're going to see in the next talk also with the use of suction sheath, whether this has changed or not the way we're treating stone and whether this will change in the future. At the same time, I'd like to end this presentation with a final slide, which is kind of summing up all the main characteristics of endolasers. And again, I'd like to thank you for your attention, keeping in mind that Holmium YAG can be a photoacoustic laser more keen on fragmenting, whereas TFL and Thulium YAG in a pulsed way, they can help you much more with dusting because of the lower peak power. Thank you very much.
I know that you can hear me, but I cannot start my video. Okay, now probably I will be able to start it. Perfect. Eugenio, thank you very much. It's an excellent presentation, really. It is excellent because it's not that often that you underline, not you, but we underline as urologists also the technique. We always discussing about the settings, but not about the technique itself, which I think, and I saw in your slides, painting is what is really needed, because if you stay, let's say, at the same time, always in one spot of the stone, eventually you will create a fragment. So you need to adapt the technique also. We have some questions for you and of course for the whole panel. And one of the question is regarding the settings. You underlined that especially in your last slides. Why we are not that sure about the TFL as we are for the Holmium laser. And to expand this question, I would also ask you, are you going to do more than 20 joules for TFL? Do you have any constraints about increasing the temperature inside? Are you going to increase the frequency to more than 80 hertz? Let's say, because you have the possibility, you have the capability of the machine. And eventually, why you think as a urological community, we have not come with an agreement about the settings? Is it more research that we need, more clinical practice? What is your opinion?
So my opinion is that in terms of efficacy, it will be always difficult to realize what are the most effective parameters, because like you correctly said before, that depends very much on your technique, which is the speed that you move around the stone, but also the distance between the laser fiber tip and the stone. But I think as a urological community, we can reach an agreement in terms of safety for settings, which is the most important thing, because first you have to be safe, and second, you have to be effective. And in terms of safety, I usually recommend and stick to the recommendation not to go above 20-25 watts in terms of power. And power, you can obtain it by multiplying the joules by the hertz for the kidney. And especially in the ureter, never come above 10 watts. But what's most important for me in the ureter is frequency. Because when I'm working in the ureter, as an endourologist, procedures in the ureter, they're not my most favorite ones. And my priority in my mind and what I teach my residents is always, it doesn't matter much what settings are you using. You have to keep in mind that your priority is never hitting the ureteral mucosa with the laser. So as long as you're good with increasing frequency, but keeping the ureter safe, then it's good. But at least in my hands, I'm not comfortable going above 10 hertz in the ureter.
We do have an interesting question. Do you actually change your way of thinking about the laser mode or the settings when you have to deal with a forgotten and retained stent ureteroscopically? Does this change your practice, Eugenio? Interesting question from the audience.
Yeah. I never thought of it, honestly, but in a way, it becomes an even more complicated, especially if you are in the ureter. It becomes a more complicated procedure, and then my idea is always not to touch the mucosa with the laser pulses. So my gut feeling is that, and what I usually do in these cases, is never raise frequency, because the effect that you get with your laser is not the frequency. The effect that you get from the laser is the energy that you set on the machine. And once you have a good effect, and once you have your effect, which is clear, then the frequency is just the speed that you're working with.
And my feeling is, at the end of the day, you may, for these cases, you need less energy, because it's not actually a stone, it's calcium phosphate a lot of the cases, and it breaks easier. Now, another interesting question for you. Is there a combination, is there a possibility in the future, or if it exists, the combination of Holmium and Thulium laser as the principal, is this technically possible?
So there is a machine which I never seen, and that you know very well, which is combining a low power Holmium and a continuous wave Thulium YAG. I don't know if it is still marketed. Theoretically, it is possible. I don't know if companies are really motivated but it would be really interesting, because you can combine different, but what companies are trying to do is that for a single technology, you can expand by changing few parameters. For instance, Holmium, it started with a very short pulse, then long pulse appear, then pulse modulation, MOSIS, for instance. So I see companies more concentrated in having a single technology, more versatile, rather than putting together different technologies. Although for me, it would be really interesting to have such a machine.
Okay. Eugenio, please also, all of us, please try to reply the Q&A, because there is a question for you also, Eugenio, if you can.
I reply on the chat box.
But don't show that, just reply the settings, because this is at the end of the day what is needed. Eugenio, one last question for you, because there are so many things, so many lasers out in the market. And you pointed out, if I prefer dusting all the time, I would use the TFL, and I fully agree with you. And work, do you have to work in a distance from the stone, or to contact the stone with the TFL? Because this is a tip and trick, a practical one. So what do you think?
Definitely.
You have to.
So
sorry.
No, sorry.
No, please go on.
It is very important to keep this in mind, that thulium fiber laser is almost a contact stone. 90% of the energy is absorbed by water at 1 millimeter of distance. So many people that have been using Holmium are really disappointed when they try TFL, because they try to keep the same distance from the stone, and they say it's not working, the stone is very hard, and things like that. You have to kind of change the technique when you're using TFL and you are dusting. Okay, and even worse when you're fragmenting, I would say.
Now the $1 million question, Eugenio. If I have to buy one machine, should I change my practice for stones and only stones? Do I have to change my practice from the Holmium to TFL, or we are not ready yet? What is your opinion? Subjective one, but you know.
I will go against the common sense and what companies like to hear. So if you've been using Holmium since 20 years, and that's part of your practice since 20 years, and you're happy with it, and you have nice results, I don't see honestly any reason, apart from your curiosity and your intellectual well-being, to change to TFL. If you're a starter and you're let's say doing a lot of flexi and you want to add suction, for instance, and you really need very thin dust, perhaps you don't do a lot of PCNL because it's not really your thing. TFL is, I would say, an excellent laser. It works everywhere. You don't need a special plug in the OR, and it's very silent and it works very well.
And we have a couple of similar questions. Are you happy using the thulium laser for very hard stones? This is a question from the audience.
I would say yes. I would say that calcium oxalate monohydrate is not a big concern for me. When I try to dust it, it doesn't make me very slow, because once you have the good technique and you understand the distance that you have to keep, it's good. I'm disappointed with cysting stones with TFL, because TFL is burning the stone rather than treating it. But I mean, I don't see many kind of, I work at a high volume center and I'm handling less than 10 patients per year with cysting. And also bruchite can be an issue, which is a very hard stone. But again, it's not very, very common.
And it is a problem also with the holmium, the bruchite, it takes some more time. So, Eugenio, thank you very much. For those of you that you are discussing about still about comparing the lithoclast for the ureter to laser, please use the laser all the time. This is the message that we want to give to you. Victoria, I think you have the best presentation, not the best presentation, the best topic actually.
Your screen sharing is paused. You are screen sharing.
So
you have started screen share. Participants can now see your application.
Sorry, there is a
Sorry about that.
No worries, no worries. So, Victoria, please go on with your presentation, and I'm pretty sure we'll have a lot of questions.
Thank you so much, Professor, and thank you for the invitation and the honor to present today. I'm going to talk about the role of suction in dealing with stone dust and fragments. My name is Victoria Yares. I work at the Medical University of Vienna. So, as we heard, there are a lot of advancements in endourology and retrograde intravenous surgery, including these new lasers and new techniques. But just because we're able to create this really fine dust does not mean we're really improving stone-free rates. In fact, if you look at this multi-center study, including over 6,600 patients, they found that fragments were left, residual fragments with a cutoff of 2 millimeters in over 21% of the patients, and 51% of these patients needed a second intervention in order to achieve stone-free status. So the question is, how do we really improve our stone-free rates and achieve the best results for our patients? We know that suction has played a role in PCNL for 25 years now and has been implemented in different ways. So you can see you can use suction either through your energy device or through the scope, like the super mini PNL, or through the sheet. And this in PCNL has shown to improve visibility, to improve stone clearance, reduce operating time, decrease the intravenous pressure, and also reduce infectious complications. So the question for us is, how can we translate this success that we have seen with suction and PCNL into RIS to address the main challenges that we are facing, which to my mind are the poor visibility due to the stone dust and the snow globe effect. We have heard about the dust hills before that can be a challenge and can obscure fragments that are left behind, and also can make it more difficult for you to maneuver throughout the kidney. The difficulty of removing small fragments in the kidney, residual fragments or dust being left behind and settling in the calyces, especially the lower pole calyx, that then show up on imaging and
ESEUT staff, Timothy Engels, Arnhem, ML, to everyone.
Can lead to auxiliary procedures need to be performed, and also the risk of increased intravenous pressure and temperature. We know that suction has been implemented into RIS since 2018 in the development of access sheets. We can use suction with access sheets actually, which has led to higher stone-free rates, shorter operating times, lower infectious complication rates. However, there are still some limitations because we're not able to maneuver these access sheets into all parts of the kidney, and therefore not able to clear all of the fragments and all of the dust out of the kidney. So this problem has been addressed by Dr. Gohar and colleagues by implementing suction directly into the scope and rather bringing your scope to the stone than to follow the idea of bringing the stone towards your scope. So they've implemented the suction into the scopes by using 2 3-way adapters that they mounted onto the URS, one for an inlet of the suction and another one for the inlet of the irrigation. And they have investigated this in a study where they've treated 30 patients with this direct in-scope suction and 28 patients with a suction urethral access sheath. They have shown that there were minor postoperative complications. It was safe and feasible to do, and they were able to reach all of the parts of the kidney within this study, no significant differences in the stone-free rate between the 2 techniques. As you can see, they were able to suction out very fine dust that can be collected and then sent off for analysis. However, the mechanism of those 2 3-way connectors was a bit hard to handle. It led to increased operative times. And you, as we heard before, through the channel, you can only aspirate dust that is finer or about 250 microns because you're using the channel or the working channel of your scope. This since then has been implemented into the scopes directly. You can see one of the suction scopes, single-use scopes that now has a suction valve with a suction connector that you can activate while your lasering can maneuver throughout the kidney, and the dust is then suctioned off. And as you have seen, you can send it off easily for collection of the specimen. With these suction scope with direct in-scope suction, you can remove the debris as you're going, minimize the visual loss that you might have due to the snow globe effect, and reduce intrarenal pressure and temperature. But keep in mind, you really have to create fine dust below 250 micrometers in order to be able to suction it and work really efficiently. So you have to spend the time to dust, and you have to adapt your technique in using these scopes. There's an ongoing multi-center trial right now, and we're awaiting the results, which I think will be quite exciting. This concept of going where the stone is rather than bringing the stone towards you was then also in 2022 adapted into urethral access sheaths with novel flexible vacuum-assisted urethral access sheaths. As you can see here on the image B, these sheaths have a bendable tip that you're able to maneuver into the pelvic calyceal system and to all of the calyces in order to suction where you need to go with the suction sheath. They have this oblique suctioning channel with a pressure regulating vent that you can cover with your thumb to increase the suction capabilities of these sheaths. Otherwise, you use them like a normal suction sheath. This has been tested first in manometric model in porcine kidneys and has shown to reduce intrarenal pressure and also to improve stone-free rates. This then has been taken into clinical studies. This study using a flexible navigatable suction urethral access sheaths, or as the authors have coined the term, fans, has shown, especially for the 10 French sheet, stone-free rates of 98% after 24 hours with a cutoff of 2 millimeter fragments. They were able to reach all of the parts of the kidney without any additional procedures needed, and there were no infectious complication rates here. And as you can see on the images, the tip of these access sheets is really bendable, and you can really go where you want to go in the kidney. So here you can see different types of these access sheets with the bendable tip. then the suction port that goes off to the side is connected oftentimes to a specimen collector, so you can directly send the fragments and the dust off for analysis, which is quite nice, and then is connected to your suction. And you have this suctioning vent, which you can either cover with your thumb, or in newer generations, they have some kind of mechanism that you can cover it permanently. These sheets can be advanced past the UPJ, as I said, and navigated into all of the renal calyces. They are able not only to remove dust and debris, but also stone fragments, and they reduce pressure and temperature. You can see here a case where one of these access sheets was used to treat a quite large 2 centimeter lower pole stone in a quite acute angle. As you can see, the scope is really bendable. And this stone was fragmented first, and then with the tip of the sheath, you can go over the fragments and really vacuum them up. Then take your scope back to most of them have a mark that shows you how far you need to go in order for the fragments to be suctioned out. This, in fact, needs a bit getting used to. There's somewhat of a learning curve because you need to coordinate both of your hands. You need to move in and out with the scope multiple times, and you need to learn how to control your irrigation, because you will need more irrigation fluid as you go along, since you're continuously suctioning. But there's a really nice step-by-step guide that explains the use of these access sheets step-by-step, explains all of the pitfalls and takes you through the operation theater setup and all of the steps of the procedure. So I can really recommend watching this video if you are thinking about using this technology. We now also have the results of the first large perspective multi-center study that was conducted in 25 centers in 20 countries, and had included 394 patients. The aim was to evaluate stone-free status and also complication rates. The authors have graded the stone-free status. Grade A was 100% stone-free, B, a single fragment not larger than 2 millimeters, C, a single fragment between 1 and 4 millimeters, and D, multiple fragments or one fragment larger than 4 millimeters. And the results are quite nice. You can see that stone-free rates are really high, with 97.2%. For grade A and B, which, to remind you, is either 100% stone-free for grade A or a single fragment not larger than 2 millimeters. They had really low complication rates and no cases of sepsis, and the reintervention rate for the patient was only 2.8%. So the authors concluded that this shows the potential to be a game changer in RAS with these high stone-free rates and low complication rates. We now also have the first meta-analysis and systematic review, which just has been published last week, that compares 16 studies, 5 of them are RCTs. And results of this show that the use of suction in RAS is in fact improving stone-free rates, led to reduced overall and infectious complication rates, and to a reduction in length of hospital stay for our patients. So in my mind, suction definitely has a role in the future of endourology. This can lead to a paradigm shift in how we manage stones, and rethink from a strategy of rather fragmenting and basketing towards dusting and suctioning, potentially a reduction in stage procedures and a shift towards more outpatient-based stone treatment. So to conclude, suction in RAS shows promising results and is improving outcomes. It has the potential for expanding indications and reducing complications, and it holds exciting future prospects with the ongoing research and innovations. However, there still is a need for more robust evidence on this and also standardized reporting, and we have to keep in mind, as always when using new technologies, that some training and adjusting is needed here. Thank you so much.
Victoria, thank you very much for an excellent overview. I think it's relatively new, and I'm sure that a lot of us, we are not familiar with the suctioning, and a lot of our audience, and this is mainly we don't have questions apart from one. So we have one question. The first one: the use of suction is very interesting, but is it really possible to use suction access sheath in all of our patients? Actually, that's supposed to be my very last question, Victoria. So for everybody, and the same Maro is asking also in the same question. Is it placed always at the UPJ, inside the kidney, at the lower pole calyx, or not? And I would say, does the suction makes the access to difficult location stones easier? If I have to expand the question, so suction for every case and suction for every location of our stones. And where do you put the access sheath regarding the suction?
I think, like with everything, it's a case-to-case decision, and still a decision if you want to put an access sheath at all or not. For the access sheaths especially, some size stones might not need an access sheath to be placed, and we all know about the risk of placing access sheaths, the risk of urethral injury. So I think I would decide on a case-to-case base, and also on the availability of the scopes. If you only have suction scopes, why not use it? It's an additional additional technology that you can use that will not harm the patient and can improve your practice. But it also depends on the availability of the scope, and also I think there's costs to keep in mind with this. So I think it's important, like with every stone patient, to really think about your strategy before you start the procedure, and then decide what you want to use.
I think you pointed very well, Victoria. This is it should be standardized, and it's very difficult to standardize the stone cases because every stone patient is really different. Of course, if you have it, because we are doing studies in our department together with Thanos about the suction in PERC and flexible ureteroscopy, and we do see a difference in our stone-free rate and in the way we have a better view inside. I have a very interesting question from one Greek friend, actually. What type of pressure irrigation you use when you use the suction devices? Is it continuous irrigation or intermittent irrigation when you have the suction device in place?
So I've used it both with a pressure roll pump or with bags, irrigation bags, with one bag on pressure and another one without. It works well with both. You just need to keep in mind that you need more irrigation fluid, and that the staff in the theater needs to be aware that they need to change the fluid more often in order for you not to lose vision or for the pelvic-calyceal system not to collapse. And this is what I meant before. It takes some getting used to also for the staff to adapt to these new technologies and the way the irrigation is used here.
Okay. And because I'm very interested in suction, as I said, is a relatively new kid on the block. Let's make some decisions, the four of us, regarding the suction. Do you think that regarding the benefits of the suction, do you think that the reduction and regulation of the intrarenal pressure is one benefit of the suction at the end of the day? The answer is yes or no?
This will be a big benefit of suction. Yes.
Do you believe that using the suction and the dusting as a combination will really reduce the trauma from basketing and using forceps and going back and forth into the pelvic calyceal system, do you think that this is also probably or possibly a benefit of using the suction devices?
I can take the question.
Yes. Yeah, please.
Yes, I mean, to be honest, you won't basket the dust, but the dust in the lower pole is difficult to get rid of, and it's very crucial for infectious stones. So the suction could be ideal in such cases that you're afraid of a septic shock or urosepsis. But be aware of the fact that if you overuse the suction, you may have also bleeding.
So Victoria, because of Thanos, this is a good point actually. How do you balance between the irrigation and the suction? Clinically, I mean, because there cannot be a guideline on this, of course. But how do you balance it as a tip and trick? Give us what you do in your everyday practice.
So we start as normal with the irrigation, and then suction is mostly used intermittently. And at those times where you use suction, you then have to stop and reevaluate if you need to increase your irrigation or if you're still fine. It's just something that you get on visual feedback. You can see if the system is collapsing on you, then you need to either reduce your suction or to increase your irrigation while you're going.
And in your clinical practice, let's say Victoria or Eugenio or Thanos, do you think that in your clinical practice, because there is not enough evidence, do you believe that the OR time is really decreased by using the suction? And as Thanos mentioned before, the infectious complications are really decreased because of using the suction. Give us your experience about OR and the infection rate.
There are studies where the sieves is reduced, and once you can see better, you can operate better and quicker.
Yes, but you also have to keep in mind, at least in my experience, that the first 15-20 cases, the OR time will skyrocket because the team is not used to this new technology. It's a new learning curve, not very long, but still it's there.
Not very long though.
So the first cases, honestly, I was really disappointed in a way that I thought it could be easier to start with. And also I would say that I'm still making my way through it. There is a situation where I'm not comfortable because Victoria usually said correctly before that you really use a lot of visual feedback to avoid collapse of the cavities, but you are trying to do as you do with PCNL, that you go out with the scope and you try to eliminate fragment. And when you are doing this movement, you are like 30, 40 centimeters away from the kidney, and you don't really see what's happening in the kidney while you are aspirating the stones. So we definitely need some intrarenal feedback that is telling us what's happening when you lack visual feedback.
But Eugenio, I mean, just to speak the word of devil, I mean, this is for scientific and research purposes mostly, because in clinical practice, I know that it's not a big, huge worldwide experience with suction in many centers, in everyday average urologist. But we don't see a lot of problems afterwards. So yes, this is a point that you made, but up to now, the clinical evidence we have, it's not that much of a complicated procedure. And the last two questions that I want to ask Victoria is actually one question, Victoria. Do you believe by using the suction, we will be able to expand the indication of flexible ureteroscopy for the average urologist? Do you believe that it will make us better to go for higher volume stones?
I think it will enable us to go for higher volume stones. I think, as we heard, it needs some time to get used to it, but once you've adapted to the technology, does allow you to move faster since you have better view. We know that it decreases the intravenous pressure, so we don't have to be as concerned for the risk of infection and sepsis if we can control the intravenous pressure during our procedure. But I think there's still a place for PCNL if that is implied in the question. Yes.
Okay. We have one question. We will end up with 3 more questions from the audience. So I don't want to leave anything unanswered. So do you believe that the composition of the irrigation fluid will play any role on the suction effect, Victoria? This is one question from our audience.
At this point, I cannot really see how that would influence the suction, but this is something that needs to be.
Another question for all of us. Because the topic is dusting, so we have one question: is there a risk for clogging JJ stents of Gibbon's JJ stents after dusting? Have you ever had this in your experience? Thanos?
No, I don't believe so, to be honest.
I haven't seen it myself also. And Thanos, the last question goes to you because you had the presentation, the very last slide. Do you use artificial intelligence or your intelligence for deciding to treat the stone? Tell us.
Actually,
it's
our intelligence. It's an MDT consensus, and we all discuss the cases in our department. So it's not a one-man show. It's nice to discuss the cases and the parameters. And until we have the modality of AI in our new scopes, it's good to use our intelligence. Thanks a lot.
Okay, so we have to thank all the attendants, because if you are not you guys asking all these questions, there is no point to have a webinar. This is from the European Association of Urology, made and performed for you. I can see that you are from many, many countries attending, and this is very nice for us. Your feedback is also and always needed to make us better. And closing this section, I have to really thank our presenters for excellent presentations and excellent discussion, I think. So thank you for being here, both the presenters and the audience. See you next time. Ciao.
Happy summer to everyone.
Bye.
Bye-bye.